Good morning. Can you hear that okay? Jerry, wave at me. Hey guys. Hi Jeremy. Good morning everybody. Hey, this is the first time we're doing this live streaming thing, and so I'm hoping everybody online can hear me. If you can, just give me a thumbs up or something, because I can see some of your screens, and some of you need to back up because your head's really big. Hey Jeremy. So Brenda, I hope Brenda's not at the Lansbomb Center. That'll be funny, because I told her not to go there. So I'm going to go ahead and do the STEMI report real quick for her. And Jackie, you can come up next. And there's just a few slides, so you can come on up. So what she's seeing here is can everybody see the screen? If you're streaming, can you see this? Can you see the PowerPoints okay? Everything good? All right, so 2232 received a call, 66-year-old male with complaining chest pain. Arrived at 2245, patient found clammy, cold, diaphoretic, and stating, feels like someone is sitting on my chest. Pain 6 out of 10, it's 30 minutes prior. 2248 EKG obtained, sinus brady with elevations 2-3 AVF, depressions in AVL and V2. They gave aspirin at 2251. BP of 96/60, decided not to go nitro, great. 2252, 20 gauge IV, 2300 confirmed STEMI. So we are 15 minutes from when we arrived to confirm STEMI. Arrived at Union Hospital at 2308, and looks like the balloon across the lesion at 002. Not bad at all. EKG to balloon is 74 minutes, door to balloon with 54. That's pretty good timing. So she's put the numbers down for 2018. We ended up at 96.6% overall, which is awesome. I think she had, yeah, she told me the other day that she only had the one case that was really a decent case to talk about, and that was a great case, so the numbers were really good. So I just we're going to move on to trauma next. Let's see how this works. See if I can break stuff here. Please work. Please, please, please work. There you go.
Okay.
And stay in front of the camera.
Oops, sorry.
I can see you here.
Okay.
And there are people logged in. This is the screen you're looking at. They'll say, so if it's one.
Okay. All right. Can you hear me? All right. I'm a pacer, and Barry just told me I had to stand still. So Maddie started a group of papers around. Take one of those. We're going to do them at the end. So if you remember last audit review that we had here, several of you had asked me about the different criteria and stuff we used. So we're going to talk about that. We're going to talk about a really cool case that one of you guys brought in, and then we're going to use that criteria to figure out that case. All right. So trauma alert for you guys is a little bit different than it is for us. Some of the components are the same, okay, and you'll recognize some of these. So all we need from you is whether or not it's a trauma. And then once it gets to us, we have to determine what level of trauma. So I took this right out of your protocols. So for you guys, a trauma alert is vital signs on a level of consciousness with a traumatic mechanism of injury, right, that has a Glasgow equal to or less than 13, or a systolic less than 90, or respirations are too high or too low, less than 10 or greater than 29, okay, or it requires you to support the ventilation. That would be a trauma, right? That would be a trauma alert. So you're gonna, if you don't have those, you're gonna assess the injury. So I have a mechanism of injury, okay? So it has to have a mechanism of injury, and surprisingly, that does confuse some people. So I want to know, is there a penetrating injury to the head, neck, torso, or extremities? Okay, here lately, it seems like you've had a few of those. I want to know if there's chest wall instability or deformity. So is there flailed chest? Do I have paradoxical breathing? Is there something that makes me really nervous about this patient with a mechanism of injury? I want to know if there's 2 or more proximal long bone fractures. Sometimes your big MVCs will have that easily. Is there crushed, degloved, mangled, or pulseless extremity? That always makes us a little nervous. Is there an amputation proximal to the wrist or ankle? Is there a pelvic fracture? Is there an open or depressed skull fracture or paralysis? If you suspect any of those, it's a trauma alert on your part, right? And that's all I want to know. Do you think this is a trauma alert? Is there an adult patient that fell greater than 20 feet or a child that fell greater than 10 or 2 to 3 times their height? Children are not very tall. This confuses medics and this confuses nurses. We had a case where an infant fell out of the mom's arms. She tripped. The baby fell out of her arms. He was 8 weeks old. I guarantee you that was 2 or 3 times his height, okay? Are they a high-risk crash? So there's intrusion greater than 12 inches in the occupant side or greater than 18 inches at any other site. Were they ejected? Was there death in the same passenger compartment? So your patient's alive, but the other person died. Is there a suspicious injury? Sometimes it's just your gut telling you, ooh, this is not cool, okay? Were they an auto versus pedestrian, a bicyclist that was thrown? Were they run over? Was there significant impact? Was the car traveling greater than 20 miles an hour? A motorcycle crash greater than 20 miles an hour? You got a couple of those too. Then you got to think about those special considerations. Are they older? Are they young, right? Because the really old and the really young make us very, very nervous because they don't do things the way the rest of everybody else does. Are they anticoagulated or have a bleeding disorder? And those are actually 2 different things. Bleeding disorders are typically diagnoses of disease processes. Were they a burn patient? You've had several of those lately. Are they pregnant greater than 20 weeks, or is it just your decision as the medic to say, I don't like what's going on here. I think this needs to be a trauma alert. That's all we need from you guys. This is a trauma alert. One of those things, or many of those things, made you nervous. So then we have to decide, okay, so they're telling us it's a trauma alert. So we have to determine, is it a level 1 or a level 2, and then we've got some other things that we can do as well. We do that based on pre-hospital information, okay? So we make our decision based on the picture you paint for us. So we want to determine if it meets our trauma criteria, and we want to determine what level of trauma we need to activate, because one will get you the cavalry, and one will just get you a little rescue, okay? So I know it's hard to see, but this is our level 1. This is going to have a little bit of difference from hospital to hospital. A lot of it is the same, okay, because the trauma criteria is going to stay the same, but then we're allowed to put a few things in there that we and our physicians think need to be. So any traumatic arrest is going to be a level 1, okay? Not all cardiac arrests are level 1. They have to have a mechanism of injury. So if you got a car versus pedestrian, a hanging, a drowning, a burn, something that's caused a traumatic arrest, we're going to call a level 1. If they are intubated or you are assisting their ventilations with a mechanism of injury, we are going to call a level 1. Any signs of respiratory insufficiency, a respiratory rate less than 10, greater than 29, that matches yours. Systolic less than 90 at any time. So when you guys got there, their pressure was in the toilet, but yet you bolused them and now it's up. But when you got there, it was 70, and now when you got to us, it's 100. They're a level 1. Age-specific hypotension in kids, remember your PALS algorithms, 2 times their age plus 70 is what you want your systolics to be. If their heart rate is greater than 120 in the adult or specific tachycardia in a kid, remember the littler they are, the faster their heart will beat on a normal day. If they're febrile, their heart will beat faster. So do I have a mechanism of injury because I had a sick kid and they were traveling and had a car crash? Okay. Burns greater than 20% of their body area with inhalation or a respiratory compromise. Okay. This one gets tricky because you guys will bring us a burn and you're like, they didn't call it trauma alert. Well, it didn't compromise their airway. Okay. Active or uncontrolled hemorrhage, any source, Glasgow's less than 8 with a mechanism of injury. Penetrating trauma to the head, neck, torso, or groin. That one's a little bit different than yours. Mangled, pulseless, or crushed extremities. Amputations proximal to elbow or knee. And any trauma patient that gets blood or blood products to maintain perfusion. Okay. They're in the toilet and we've got to give them blood. Deterioration of a previously stable patient. We've all had those. You're like, they were fine in the ambulance. You all got them and I don't know what happened. Or the emergency department physician or charge nurse discretion. So maybe you're seeing okay, but by the time you get them to us and you transfer them over to the bed, now all of a sudden they're not okay. Okay? That's a level 1. We also have level 2. Okay? So they don't meet our level 1 criteria, but they still may meet our trauma criteria. So they have a glass scale less than 11 with a mechanism of injury. They were separated from a motorized vehicle at greater than 20 miles an hour. Okay, they fell out of the car, fell off the motorcycle. They have an MVC with a rollover with an ejection from a vehicle or a prolonged with injury. So they're like a prolonged extrication. The intrusion is 12 inches in the occupant compartment or 18 inches elsewhere. That one looks just like yours, right? Auto versus pedestrian, cyclist thrown, run over, or with significant injury or impact. Death in the same passenger, greater than 2 more extremity fractures, any long bone fracture, okay? Lots of blood loss with a long bone fracture. Depressed skull fracture, unstable pelvis, CNS involvement, paralysis, chest wall instability, flail chest, things like that. Second or third degree burns greater than 10%. So you still might get a level 2, maybe not a level 1 if you didn't catch the airway. High energy dissipation, rapid deceleration, right? Because it's not the fall that kills you, it's the sudden stop at the bottom. So ejection from a motorcycle, ATV, animals, blasts or explosions. Striking a fixed object with momentum, okay? That one I've seen blown off a few times in the past few months. Struck a tree, struck a pole, that's a fixed object, okay? Pregnancy greater than 20 weeks, falls with injury, adults over 20 feet, pediatric 2 times their height. High risk falls with a head injury if they're over 65 and anticoagulated. They're on the wonderful big Coumadin that we all love so much, okay? Or the new ones that you can't stop. Or the ER physician or charge nurse discretion. So you don't have to decide level 1, level 2. That's our job, okay? All we want to know from you guys is it met my pre-hospital, my EMS trauma criteria. Then we're going to determine, are you going to get a 1 or a 2? So let's talk about a case, okay? I did not get with Dr. Lynch in time to get the pictures into the slides, but later, if you want to see this, he actually does have a couple pictures of this patient. 911 call for a suicide attempt, self-inflicted lacerations, okay? That seems to be kind of a common theme here lately. This is a 53-year-old male that admitted to a suicide attempt. When EMS arrived, he was sitting in a chair with a steak knife at the table near him and PD at his side. So the call came in at 1824. They were dispatched at 1827. That seemed a little long to me, but I don't live in your world, so. En route at 1829, on scene at 1831, so that kind of tells you they were close. They were at the patient at 35. They left the scene at 51, and they got here at our hospital at 1854. So total scene time was about 20 minutes. Transport time was 3. So from the 911 call to our ER was 30 minutes, okay? 30 minutes. So the initial impression for EMS, he had a superficial laceration to the left ankle. He had a superficial laceration to the left calf, superficial lacerations to the left wrist, but he had charted significant bleeding from the right ankle. It was described as an arterial bleed that was pulsating and shooting out of the laceration. So he did a pretty good number to the other ankle with a steak knife, okay? So they got 2 IVs in him. Left AC, they put a lock. The right one, they put 250 cc's of normal saline in. They drew some labs, did a finger stick. They did direct pressure to the right ankle, okay? That wasn't doing the trick, so they put some ABD pads and some more direct pressure to the right ankle. That still wasn't doing the trick, so they placed a tourniquet, okay? Appropriately. So his pressure was 110/78. He had a heart rate of 96, which in my opinion, that's pretty good considering he was shooting blood out of his ankle. He had a respiratory rate of 14, so he's pretty cool, calm, and collected at this point. SATs are good at 95% on room air. His pain was a 6. He was alert and oriented to everything, and he had a glass scale of 15. So he's cool, calm, and collected sitting there when EMS arrives. So initially, his skin was pale, and his patient reported feeling dizzy, signs and symptoms of shock, okay? First sign and symptom of shock. Actually, that's the second stage. By the time we see that, they're a little bit into progression. Both of them resolved during transport. Remember, your medic gave fluids. So the patient denied any medications or allergies, but he did have a significant past medical history that we figured out once he got to us. So the patient, of course, was on a 2nd floor apartment. So the medics had to remove him from the apartment via stair chair, and they put him in the squad and they brought him to the hospital. Because, you know, that's easy, right? Cardiac arrests don't happen in the middle of a giant arena. They happen in that tiny little bathroom in the back hall of a single wide trailer. So when we get into ED, we do activate a level 1 trauma, okay? And we're going to talk in a little bit. We're going to do that together. So the iron states a laceration to the bilateral ankles with bleeding controlled. At some point, you guys had to have told us it was a tourniquet. You had to have told us there was excessive bleeding because we knew enough to activate level 1, okay? But on the paper that I was able to look at and read, it didn't have that information. So I think that's something on our end. So our doc in the ER documents that the patient presented with suicidal ideations and depression. He had reported to EMS that he actually waited 30 minutes before he called 911. He probably went, crap, this isn't working, so I guess I'm going to call. So between the time he waited and the time he arrived, he had a whole hour. He admitted to 8 beer that day, which is pretty amazing because usually it's how many? 2, right? Everybody has 2 beers. There is a documented past medical history of depression, typo, diabetes, alcohol, drug abuse, anxiety, bipolar, schizophrenia, suicidal ideations, you know, the usual that comes along with those types of patients in second-floor apartments. So in the ER, we gave him the life-saving tetanus. We gave him an antibiotic per IV. We gave him normal saline, so 500 plus the 250 that pre-hospital gave. We did give him some morphine and Zofran because we felt a little sorry for the pain. He got a chest x-ray and an ankle x-ray, so there was negative. He didn't get any bones. Labs, his glucose was a little high. Blood alcohol was only 0.174. That's pretty impressive. Toxicology was negative, and then we type and crossed him, right, because he had a significant blood loss, so we always do that because we want to stay ahead of the game. Trauma surgeon was at the light right out here when he got the call, so he was able to turn right around and get back into the patient within 2 minutes. He notes that the tourniquet was placed at the mid-thigh about 30 minutes prior. The foot was pale, which we want, right, because you're cutting off the circulation. Bandages were just above bilateral ankles with Coban. He was responsive. His vitals were stable. He had a history of multiple suicide attempts. Left ankle was superficial. The surgeon documents that there was a pool of blood at the scene that he was told was about 6 to 8 inches squirting from the wound. And the tourniquet was working well, so he eased it off. And the bleeding remained controlled. So it worked, okay? The tourniquet worked. So how did we fix it? Well, our trauma surgeon noted that there was a saphenous vein that was about 90% transected. Remember, that remains pulled apart. So he just about did it. So he just completed it. He pulled it out, he tied it off, he sutured the ends. We admitted him to psych for a behavioral health consult, and he was discharged to Hamilton Center 2 days later. So he wasn't admitted really as much for the injury, other than he needed his antibiotics, but as much for the psych. So he did do a pretty good number on that vein. All right, so before we start talking about the alert, is there any opportunities? And if anybody's ever heard me speak, this is where I shut up and you get to talk. What opportunities were there? Come on, I can see faces. Your thoughts are rolling. Opportunities. The tourniquet was beautifully placed. Dr. Lynch was actually the surgeon on that day. The tourniquet did its job. They did direct pressure. That didn't work. Then they put ABDs on, put some more direct pressure. The only thing I didn't see documented, and I don't know that they didn't do it, was maybe elevation, okay, or an ice pack. So, but, you know, it is what it is. Okay, pull your papers out. And we're going to go through this. So what do I need from you? When you guys are calling in, what do I need to know? Do I need to know level 1 versus level 2? No. All I want to know is trauma alert. That's it. That's all we need to know. So you have a 53-year-old male that had superficial lacerations to the left ankle, left calf, left wrist, significant bleeding from the right ankle that was described as arterial because it pulsated and shot out the wound, right? That's appropriate. They put direct pressure on the right ankle. They put ABD pads, more direct pressure, put the tourniquet on, and there's your vital signs. Initially, he was pale. He told the medics he felt dizzy, and that got better after they gave the bolus and then transferred. All right, so flip to page 2. Page 2 is pre-hospital trauma alert, okay? So we have to determine if this is a trauma alert per EMS. So, did he have a Glasgow less than 13? No. No, it was perfect. How about systolic? Did it drop below 90? Nope. Respirations? Nope, he was good there. How about penetrating injuries to the head, neck, torso, or extremity? I'll give it either way. It technically didn't penetrate, but he did cut, so I'll give you the one. That's your judgment. Chest wall instability? Nope. 2 or more long bone fractures? Nope. Anything crushed, degloved, mangled, pulseless? No, he had good pulses because it was spewing out, right? Amputation proximal to wrist or ankle? Nope. He tried, but he didn't get success, did he? Pelvic fracture? Nope. Open or depressed skull fracture? Paralysis? A fall? High-risk crash? Pedestrian? Motorcycle? Nope. Well, is he older? Nope. He's 53. He's not a child. Was he anticoagulated or had a bleeding disorder, like a disease? Nope. Was he a burn? He definitely wasn't pregnant. What about EMS judgment? Okay, so based on your answers, was this a trauma alert? I agree. I think the medic did correct by calling it a trauma alert. He was spewing blood out of his ankle, and at that point, they thought it was arterial, okay? And you could say maybe, yes, on the penetrating injury, but other than that, that's about it. He was alert and oriented, other than he did show little signs and symptoms of shock. So yeah, he was a medic trauma alert. That was appropriate. Now flip to the next page, and let's decide which level he needed to be. Okay? So I only did level 1 because that's what we called him, okay? So was it a traumatic arrest? No. Was he intubated? Nope. Was there signs of respiratory insufficiency? Nope, not at all. Was his respirations okay? How about his systolic? So systolic's okay, but look at ours. Clinical signs of shock. Did he have clinical signs of shock? Yes, he did. He was pale, he was dizzy, he was bleeding profusely, and at that point, we still think it's an arterial bleed. How about heart rate? No, he was fine. He was cool, calm, and collected. Burns, he definitely wasn't a burn. Active or uncontrolled hemorrhage of any source? Yes, that's a big yes. For those of you who are looking quite confused, yes. He cut his ankle with a steak knife and it was spewing blood. Glasgow, that's good. Penetrating traumatic injury to the head, neck, torso, or groin. Ours is a little bit different. No, none of those. How about mangled pulseless or crushed extremities? Amputations? He wasn't getting blood. Did he deteriorate? No, he did not. He improved. Remember, he got better. His paleness and his dizziness went away after the medic gave him fluid. And then the ER physician or charge nurse discretion, absolutely. So did he meet our level 1 trauma criteria? Okay, so now that you know that, was there any opportunities for anybody? Was there anything that could have been done better? Was there anything that could have been done differently? No, I think it was a very good run. It was handled very well. Obviously, they were very close to the hospital. That's an advantage that the city has over those of you that work the county, okay? But when the medic placed the tourniquet, it was beautiful. It was perfect. Dr. Lynch does have pictures of it. The foot is pale. It's pulseless when he arrived. It was well placed. It did exactly what it was supposed to do. And this guy had almost no end results other than his psych eval. Questions? All right, that's it. I just have one today.
Hello. Just show me how to go forward. Yeah.
Somebody mute your stuff out there. Who's ever running through the house, mute that. I don't know who that is, but.
The toilet flush.
Danielle, quit doing that.
All right, so I push here.
Yeah, push there.
Okay.
Pop up right up there.
Perfect. So hello, everybody. I'm happy to be here. I just wanted to share a few things with you. A year ago in California, Los Angeles, a lot of neurologists gathered together and changed our life, your life and my life. They changed the guidelines for the 2018 stroke indication and contraindication. That speed us up. We had to do things faster and better. Therefore, we are kind of together in everything. So we're asking you to do things better and faster for us. So just to situate things, an acute ischemic stroke is the second cause of death in the world, the 5th in the United States. Approximately 700 people had one due to a blood clot, and 1/3 of those is a large vessel clot. It creates a lot of brain damage, disability, and death, and they have come up with that thing, time loss is brain loss. And every minute there's more brain damage, and we're going to see how much. So we need rapid, urgent treatment to improve the outcome and the disability and improve recovery. So 1 minute, 1 minute, 1 minute's nothing. It's 1.9 million neurons, 14 billion synapses, and 7.5 miles of myelinated fibers, the connectors. So what did they change? The first thing they changed was the TPA, the clot buster, has been increased up to 4.5 hours after the initial time of onset of symptoms. Now you'll see neurologists, our medical doctors, they're like philosophers, they will change in this guideline, which is 375 pages, they change back and forth. Initially, they give us the real guidelines where they tell us 4.5 hours after the initial onset, but they say, but be careful with more than 80 years old, and be careful if they're diabetic. But later on, they kind of try to do things more towards people getting TPA. And they want a faster door-to-needle time down to 45 minutes for us. So 45 minutes is the time the registration clerk registers the patient until the time the nurse pushes the first dose of TPA. 45 minutes is nothing in the ED, as everybody knows. And we have to always look at the benefit for the patient, and it must outweigh the risk for the patient. Again, the risk is 6% of generalized bleeding and 3% of intracranial hemorrhage. So they have changed that for us, which has created a lot of changes in our processes. The other thing they changed was the other way of getting rid of a clot. Think of a clot, think of the brain exactly the same way we think of the heart. When you have something that's obstructing blood flow, then you need to remove it. Years ago, with the heart, we did the IV nitro, then we did the TPA for the heart, for the STEMIs, and now we do the PCI. For the stroke, is the same thing. You need to remove the clot. You can remove the clot by dissolving it with TPA or by mechanically going and retrieving the clot if the clot is big enough. So the mechanical thrombectomy are done by the interventional radiologist. We have 6 of them at IU, and they're mainly radiologists, but you can enter that field through other, like neurosurgery or other specialties. And they go through the groin, they go to the brain, and they have a catheter that's not bigger than one of my hair that goes over there that grabs the clot and retrieves it. It used to be 6 hours after the time of onset, and now it's up to 24 hours. And it has to be done in a comprehensive center where people do that every day, not once in a month or something like that. The best outcome for the major strokes for large clots is the TPA plus the thrombectomy. So, and you can see where I'm going. Right now we have to do things faster and for more people. So our volume has increased, and we have to get better together to do this faster. So we have to change our processes, and there's the things I would like for you to help us with. It's very stressful when we get one of these patients in the ED because we have to meet that criteria, and actually right now we're not. So this is a criteria for CMS, it's a criteria for the stroke accreditation, it's a criteria for everybody. So everybody has to, that's why I will jump on you or come outside and on the bay to see what the story is, and everybody who knows me, I'll just try to shovel things around. We need a better process, and I'll tell you how you can help us do things faster and better. So I have seen that the process works the way we are supposed to do with 3 things. Is recognition of the stroke, and sometimes it's very easy, everybody, including the patient, will tell you, but sometimes it's not easy. And I will go through those with you. The second thing is the patient has to go to CAT scan before a physician sees him. So you have to go, you call, you go to CAT scan, and then you see us. Same thing with the nurses. The patient presents with triage, goes to CAT scan first, and then sees us. And the third thing that's very important for us is the ED physician has to order the TPA and not wait for another neurologist to tell them, okay, it's okay for you to give the TPA. And something I want you to know, we ER physicians get sued way more by not giving the TPA than giving the TPA and having a bleed. So our standard of care and our specialty is to give TPA. So we will give TPA if we think it's necessary and beneficial. So remember, you are the initiator of at least 50% of our cases, and we're very grateful for that. So the checklist is only a few things. So age higher than 18, and now it's 4.5 hours from time of onset. They have to have some deficits, and those can be very, very, very minor. So think of a pianist or somebody who does something with their right hand or left hand. If they have a little numbness or can't feel it, that's the end of their livelihood. If they get depressed, so that's important to them. Might not be important to all of us, but it's important to them. So even minor things. Coagulation status, to get TPA, your INR has to be higher than, lower than 1.7. So even people on Coumadin can get that. Blood pressure, we're counting on you if it's too high to decrease it before you get to us, but not too fast, because you can make that stroke worse. So the criteria now is 185 for the systolic and 110 for the diastolic, and the sugar more than 50. And all of these are the criteria this group is giving us to begin with, but then they twist it around and say, even if the blood sugar is less than 50, go ahead and give it, and you'll see it changes. But that's the main checklist. Now the contraindication, that also changes. So no evidence of intracranial hemorrhage, but you don't know, so that's not for you, it's for us. And clinical presentation of a subarachnoid hemorrhage, which is the thunderclap headache, one-sided usually, sometimes not, with altered level of consciousness. That's not either your place to make any type of decisions on that. Active internal bleeding, which you don't know. And the first thing they say is within 3 months, intracranial or spinal surgery, serious head trauma, or previous stroke. And then the blood pressure, and then a known arteriovenous malformation or an aneurysm. And then what's very important for us at this point, if the stories are unclear, and they always are, they always tell me different than they tell you, and then when I want to give them TPA, they even change their stories, they let me think again, and it's all of us know they change all the time. If it's unclear, just let us know that it's unclear. And at this point, in Europe they do, but at this point in the United States, we do not treat wake-up stroke, but the Germans, who are on top of all of this, are doing the wake-up strokes. Anticoagulation is a big deal and a lot of confusion amongst nurses and paramedics. So I just wanted to go through this very quickly. Somebody on warfarin, Coumadin, if their INR is higher than 1.7, cannot have TPA, but if it's lower, if it's 1.6, they can have TPA. So we have a little machine, a point of care that will tell us immediately with the blood sugar, will tell us INR 1.1, even if the patient is supposed to be on Coumadin, his INR will let me give him TPA. So no DOACs. The DOACs are things I want you to know really very well, both names, because I've seen them. When I ask you, they say, you know, they're not on anticoagulation because the patient doesn't know, but on the nursing home list, there are all these weird names that we need to remember to know. And that's important for trauma, and it's important for TPA as well. So I put them down here, the dabigatran, rivaroxaban, abexapan, edoxapan, or Pradaxa, Xarelto, Eliquis, and Saveza. What we see here, because of the physicians, the main one you'll see is Eliquis, which is apixaban, and then Xarelto. I've seen only 1 or 2 Pradaxa, and I've never seen Saveza. So those are a contraindication now, and I can bet you it will change pretty soon. No heparin, no Lovenox within 24 hours. So think the Lovenox, usually they might tell you because it's a little shot they give themselves. The heparin, think of the dialysis patient you're picking up. In the dialysis, there is heparin. So that one, if they're having a stroke on the table, they have had heparin on board. So that's a contraindication. But aspirin and Plavix are okay. Some contraindication, infective endocarditis, it increases the chances of bleeding because they throw septic emboli to the brain. Aortic arch dissection and intracranial neoplasm. Again, these are what they give in their initial guidelines, but then there is 500 pages where they tell you, well, this you can really do if you think you can do it. So not a contraindication anymore, and that's what has increased our volumes of TPA. We're doing way more TPA now than we were before these guidelines. Pre-existing disability. Somebody brought me not long ago a gentleman who had had a stroke, had a deficit, but his deficit was getting worse, and thanks to you, I was able to give him TPA. Dementia is not a contraindication. The complex migraine, the lady with a total deficit and a headache, we will give her TPA, even if we kind of know it's a complex migraine. There's always that question, and what if it's not? She's not a contraindication. Seizure is not a contraindication any longer. It was before. A mild stroke, remember the pianist, remember the person who uses their hand, a singer that uses his voice, that's important to them, so we need to respect that and go ahead and give them the TPA. Older than 80 years old is not a contraindication. I've given it to an 86-year-old. The blood sugar less than 50 or more than 400 is not a contraindication. And coagulopathy, what Jackie was mentioning before, it's a case by case. We have to discuss with the family. We have to have family input to tell them the risk and benefit, and with the family and the patient, if they can, make the best decision for them. Now they're changing. Remember I told you interspinal surgery or things like that. They're changing it when they when they discuss this. They say, if you think the patient has had an epidural within more than 7 days, you can consider TPA. If the patient has had a major trauma, recent major surgery within more than 14 days, or they're making their window lower. Any GU or GI or GYN bleeding is not a contraindication any longer, and an unruptured intracranial aneurysm is not a contraindication any longer. Pregnancy is not a contraindication any longer. Sickle cell is not one, and illicit drug use, and we've had many of them, and some of you have brought those meth users that get strokes, and that's not a contraindication anymore. And the stroke mimics. Remember, there's a lot of things that mimic the stroke, like the TOTS paralysis, the seizure, the intracranial neoplasm, electrolyte anomalies, hypoglycemia. Those are not a contraindication any longer. So what the emergency medicine physician needs from EMS is the exact time of onset. If you feel that the family is wiggling around and changing their story, please let us know. We'll try to dig further to try to determine, to see if they are in the 4.5-hour time frame or not. And the things I've seen missed by everybody, including the physician, is the dizziness. One of you brought me an anxious, dizzy lady who was actually an intracranial hemorrhage, cerebral hemorrhage. Remember, the cerebellum is ataxia, is people unable to figure things out. They're a little strange, and they can't see, and they're dizzy, so that's their primary symptom. Impaired speech, remember that, and then the visual disturbance. I can't see or I don't see here. These are all signs of stroke, and I want you to bring them as a stroke so we can decide afterwards what we do with them or not. Always ask them about warfarin, heparin, Lovenox, and the DOACs. Always ask for recent brain injury or spine injury or trauma or an operation that helps us, that gains us minutes, and those minutes are so important to us. And even if it's a small deficit, even if to you it's not important, I want you to bring that patient as a stroke to us so we can decide what we do with them. And always call it a stroke in doubt. And overcalling is always better than undercalling. Same thing as for STEMI. I'd rather you bring me a known left bundle branch block, call it a STEMI, bring it to us, let us figure out, look at the previous EKG, decide it was not a STEMI, it was a left bundle branch block. I'd rather this than we miss something, an opportunity to help that patient and that family. So that's it. Do you have any questions for me? Comments or process changes that you would like to see from our standpoint? And again, thank you for everything you do.
Thank you, Dr.
Thank you. Yeah.
All right, guys, we're just about done. I have noticed that we've got quite a few people online and it seems like it worked. Everybody, has anybody been streaming it? Jason, you said you were streaming it. Did it work? Yeah, everybody, I've had some good comments from people. So my goal is to continue to do this. Actually, this was my EMS goal for 2019 was to be able to do this. This will actually be recorded, and I will send everybody the link. Rob? I don't know. Yeah, I don't know. No, I don't know what Shane's doing. I did this because it was a goal that I wanted to do for 2019, and so when we got moved here, the opportunity got easier to do so. And so our next meeting obviously is April 2nd. It's the first Tuesday in April. It'll always be down here. EMS advisory is always at 8 o'clock, and then we'll do this. And they'll always, it'll be the same login and everything for every single thing. And they're already set up, all 6 of them for the year. It'll always be the same login, same ID number and everything for here. So the run reviews, I did some run reviews. I would like to mention some things that I found, a few things I'm not singling out, but if you're writing a report and I get a report to me that talks about a refusal, there needs to be more details. They're leaving out some key things in your refusals that I'm afraid is going to bite you in the butt if for some reason somebody in 4 years you're on a stand and you're looking at this refusal, you're going to have a hard time selling it. Okay, write it like it's a regular run. I don't care how much information you can get. The best it's for your own good. It's for your own benefit. Write the run report as if you were writing it and submitting it to ESO or submitting it to whoever or on paper or whatever you do. I'm just asking that you do a little more detail for yourself. Get those birthdays, get those numbers, get everything you need. Ask that medical history and document how many times and how you asked them if they wanted to go to the hospital. And if they're adamant, that's great, not a problem. We don't transport because you can't take those people that don't want to go, correct? Unless you arrest them, and that's kind of against law too. So anyway, the thought process is just make sure that you do in more detail. I'm afraid I just don't want to see somebody get hung out to dry or something. And I would still say spelling has been way better, even though some of you still don't use spell check. I don't get that one, but anyway. So the next thing for you, I will be mailing out for those online and see this, but there is a postcard, and this is a save the date type thing. On June 14th, we'll be doing our second EMS symposium at the Lansbaum Center. It'll be 7. I think I have secured 5, maybe 6 speakers. I think I need 1 more. My goal was to have 7 speakers for 7 hours worth of continuing education. We did it last year. We only had a couple months advance. Now you've got 4 or 5 months to get this out. And I would like if you have like volunteer services or EMS services that are close enough or within our district, anywhere close, send me those addresses and contact information so I can mail these out to them people. I want to fill up the Lansbaum Center. I think it'll be so cool. We're going to do breakfast like we do. We're going to do lunch. There'll be snacks in the afternoon, but I've got speakers. Got a couple speakers that are coming in. Dr. Kaufman's coming back in. Dr. K.R. Patel is a friend of mine who's going to do some stuff. I'm trying to get one of the doctors is going to do some pediatric stuff. He's from Raleigh, so that's something we didn't do last year. Dr. Lynch's group, one of them, I think, whoever Dr. Lynch decides is going to do it, is going to be doing some trauma stuff. Last year it was Rebecca, so maybe we can get Dr. Lynch to do it. We'll see if he feels better. So, but anyway, I would love to have as many people there as possible. We had 43 last year. My goal is I would love to double it if we could get. So please plan on. And now I've given you 4 or 5 months to get the day off and be prepared for it. So, does anybody have any questions, any comments, anything? One other thing I'd like to piggyback on Jackie. One thing we need to know, it's important for Union Hospital and Regional Hospital to know our processes. It's very, very important for you guys just to call a trauma alert. We're not asking you to know 1s, 2s, or any. We're not even asking you to. We want you to be aware of what we have here, but our biggest goal is to make sure everybody knows you're bringing the trauma in. And then it's on the hospitals. It's their responsibility to put the cavalry or a couple rescuers. That's literally what she said. And so I just wanted to reiterate that all we're doing is calling trauma. All we're doing is calling STEMIs. All we're doing is calling sepsis, right? We're calling code STEMIs, code sepsis, code stroke. We're calling those things. It is the hospital's responsibility to do what's necessary after you get them here. But if you let them that alert and then you show up and they're not alerted, then that's on them. And that's just something Jackie will need to know and Dr. Tucci will need to know and you know, we'll go from there. But our goal is for you to let everybody know they're coming. You don't need to know, hey, I'm bringing a level 1. No, you're bringing a trauma, right? I'm bringing a STEMI, great. I'm bringing a code stroke, right? Those kind of things. That's all we're asking. That way, they're more prepared here. And if, like I said, if they're not prepared here, then Jackie gets on them because that's their responsibility. They're supposed to be prepared. Everybody understand that? Hey, Jimmy.
Is there a percentage of how many missed calls of STEMIs that we have done, pro and negative STEMIs, and how many missed calls for stroke alerts of pro or negative? Is there a percentage of what our wrongdoing is?
Jim, I tell you what, I will absolutely start to see if I can get those numbers. The question for, I don't know if you heard the question was, is there a percentage or a code for how many of that we would call a STEMI in the field and it wasn't a STEMI, or we would call a stroke and it wasn't a stroke? I will get those numbers and see if I can present them in April and let everybody know. And if I can't get them, if I can get them before then, maybe I'll try to email out to the services, and so everybody will know. My goal is that, and it's a great question, Jimmy, because I don't, you know, the numbers are important, but calling them is the most important thing. Yeah. Ends up being, exactly. Yeah. So when you were on the fence, you weren't sure. Yeah. If you're on the fence, I'm saying call it. Yeah. I would rather, I know what you're saying is.
I always want to hear it towards the patient at the same time. I don't want to waste resources too. So
I understand. Yeah, right. I understand. And then sometimes, you know, those ones they'll fool you. I mean, it's definitely a STEMI or definitely a stroke, and they're not. You know, but everything pointed to it. I think you're still erring in the judgment of the patient, and that's our goal. Oh yeah, right. Totally agree. Okay. Yeah, it's a whole lot easier for the hospital to say, nope, it's not, and go back to what you're doing versus, oh crap, bring everybody after you're already here. So, anybody have any other thing they'd like to bring up? Chris? What? Oh, aspirin. Yeah. When we talked about this, I'll throw this out right now since it's recorded. We talked about this. You know, the dosage is 324, and some people are withholding an aspirin here or there. If somebody takes one aspirin in the morning, they're only giving 3. The protocols say, give 324 milligrams of aspirin. Give 324 milligrams of aspirin. I don't care if they take it in the morning, give them the aspirin. Dr. Ducey, you're okay. Give them the aspirin. That's what we talked about, Chris. Is that what we're doing? I'm just saying it now so everybody's listening to me. Everybody knows it's here. Everybody's online. If they have chest pain and you want to give aspirin, give 324. Don't cut it down if they take one in the morning. Don't do that. It's not necessary. Give them the 324. Thank you for bringing that up. So anybody else have any questions, comments, concerns? Please sign up for this. Email me if you want to register. I've got an Excel spreadsheet set up already for whoever starts. I've already gotten 3 emails this morning from just people that have been in here. So please email and sign up, and so it'll be a great day. It was a good time last time. So I don't have anything else. If you guys don't have anything, I know it's early and we got done quick. We didn't have a crew presentation this time. We will have one